Dear participants, it's my pleasure to join this meeting and provide some thoughts from the perspective of the people living with HIV. My name is Nikos Dedes, and I live in Athens, Greece, and I'm the founder and chair of Positive Voice, the Association of People Living with HIV. But the majority of my experience is based on the European network of people living with HIV in Europe, the European AIDS treatment groups, which was created in 1992. My topic, patient preferences, made me think twice about using slides. Patient preferences and expectations can best be understood and addressed within the doctor-patient relation by a face-to-face dialogue. So the success of this relation is not just knowing data and statistics, but both sides seeking a shared decision-making process. Allow me to use my personal experience to raise a couple of points. I was diagnosed 28 years ago in 1995, at a time when HIV was still a terminal condition and no lasting effective treatment had been identified. But unlike others less fortunate than I, my diagnosis and then recent infection was only 2 years away from the introduction of the so-called highly active antiretroviral treatment. At that time, the main quest was efficacy and effectiveness. We were willing to put up with any number of side effects and inconveniences, number of pills, food restrictions, 3 to 5 daily doses, dangerous drug interactions. Many of my friends and colleagues were exposed to suboptimal treatment, which in turn resulted in the need to later use what we call kitchen sink approach and throw all possible drugs to overcome resistance of the virus to the various drugs. But even the lucky ones who started on triple combinations, we all had to endure, apart from the inconvenience I enumerated above, a series of side effects, including nausea, dizziness, sleep disorders, all the way to horrendous pains, for example, after onset of kidney stones caused by one of the then miracle drugs that saved countless lives, Indinavir. One of the drugs I used, didanosine, could cause pancreatitis, or another, which I used, abacavir, should not be stopped and started again because it could cause a deadly hypersensitivity, even after one pill rechallenge. This last fact worried me when I considered a strategic treatment interaction back in 1999, which was popular at one time as a strategy to diminish continuous and cumulative exposure to drugs toxicities. And within all these obstacles, treatment success was guaranteed only if one had adherence of more than 95%. Who were those patients who could possibly achieve this? Who were the doctors most successful in this? One answer is those who shared decision-making with their patients. And here is my first recommendation. Win the game of the relation with the patient from the get-go by engaging with them to assess readiness to start and maintain antiretroviral treatment. There are various techniques, and one is succinctly described in the European treatment guidelines by EACS, the European AIDS Clinical Society, which kindly has invited a number of patient experts to sit on its panels. Here, admittedly, a slide would have demonstrated to you how simple it is and makes one wonder why this is not more consistently taught at medical schools, or where it is, retained as knowledge and practice. So while same-day initiation of treatment after establishing HIV diagnosis is feasible, this readiness assessment is essential to allow patients to express preferences and not feel pressure to start treatment immediately. I started therapy in 1997, and 2 of my 3 drugs, D4T and DDI, are no longer in circulation for reasons of toxicity. DDI back then consisted of 4 and later 2 chewable tablets with horrible taste. People likened it to chewing chalk. So in these 26 years of taking antiretrovirals, I have used 12 different unique drugs and 5 fixed dose combinations. And in my case, I changed treatment 17 times while always retaining viral suppression. Why did I do it? I changed treatment for 2 reasons. One was for convenience, considering number of pills, number of daily doses, food restrictions, interaction with other drugs, etc., which, by the way, all affect patients' adherence and are important to address proactively to ensure treatment success. And here, allow me to challenge the dictum of if it ain't broke, don't change it. In order to ensure adherence, it's good to address all of those above. In my case, changes, the 17 changes I did, were mostly, if not exclusively, because I wanted to avoid short-term side effects and long-term toxicity. When it comes to side effects, I'm sure that you are aware from articles or personal experience that many times doctors and patients rank them differently. Let me give here an example of one protease inhibitor, nelfinavir, which was first approved in 1997 in the US. During the phase 3 trials, its side effect was graded as low to mild. This particular side effect was linked to gastrointestinal symptoms and especially loose stools. Well, when it comes to gay men, the lower gastrointestinal tract is not used only for stool elimination. People felt dirty and had embarrassing moments that impacted their sex life and mental health. It took some time to figure this out since people were reluctant to speak about it. But as nelfinavir became market leader, it was inevitable to surface as an issue. This was one of those insights that we provided very early to drug development teams during our meetings within the Community Advisory Board, which was instituted in 1997 by the European AIDS Treatment Group. This group was meeting with pharma every month for many years. Feel free to ask me about this if you're interested in the Q&A. By the way, nelfinavir superseded the previous protease inhibitor, indinavir, on the merit of being given twice a day versus 3 times, and of course, indeed, the kidney stone threat. I mentioned before the difference of ranking side effects between doctors and patients, and of course, the same would be true of what constitutes convenience and simplification. And while preparing this intervention, thinking of this tension between lesser evils influenced by marketing and perceptions, I came to an obvious epiphany, which probably is well understood by you. Doctors ranking side effects surely reflects what their most vocal patients told them. Then I remembered the predominance of efavirenz in the early 2000s, the strongest ever in terms of efficacy, not least because of a flawed phase 2 choice of dose, which led to overdosing and caused severe sleep disorders and other CNS and mental health issues. Doctors and patients understandably could not resist its efficacy after years of failing regimens and resistance, and so much trouble with one patient. Subsequently, simplicity was added as an advantage to efavirenz, since it was included in the first ever triple fixed dose combination in 2006. So my second consideration statement for the day, based on this mosaic, is to try to understand the individual needs and values of patients by an ongoing, but mainly front-heavy engagement. It is worth mentioning that studies have shown that considering patients' preferences can lead to better outcomes. Engaged patients are more likely to adhere to treatment, with rates improving by 20%. Nevertheless, while 70 to 80% of patients prefer to be involved in medical decision-making, only around 30 to 40 report that they are actively involved. By the way, allow me to suggest my third recommendation: to never fail to insist to your patients to buy and use consistently weekly pill boxes. Because when you repeat something every day, it becomes such an automatic habit that you are performing it like sleepwalking. You are not fully aware of it, especially since many patients and doctors or package leaflets recommend to take one's pills before sleep. In other words, at a time when you are most tired and you might have dozed off at the TV just before you crawl to bed. So many times I'm not sure whether I have taken my pills, and the best way to make sure is by looking at the pill box. So how easy is it to conduct these types of evaluation and engagement with patients? How easy is it in an era of such noise and nonsense on the internet? While time is so limited and HIV specialists are diminishing in clinics while the number of patients are increasing, how is it possible to do it? Many years ago, the president of the Greek HIV Clinician Society told me, Nikos, the patients referred to us by the Checkpoint, a community-based testing site that we run since 2012, are the easiest to deal with. The reason was that when we diagnosed them in our premises, we immediately provided a peer-to-peer orientation on HIV as a condition, the existing therapies, and indeed all issues pertaining to living with HIV, including sex life implications, coping, and disclosure strategy, and anything that would ameliorate their anxiety. So my fourth recommendation is for those who may have underestimated or simply taken for granted, but not engaged with local people living with HIV support groups, to seek them out, actively request their material for your clinics, and refer your patients to them for advice and guidance. This will save you a lot of time and make someone else explain and teach the patients how to seek counsel with you in a productive manner. It is worth mentioning here that in most cases, treatment begins when people experience no problem or discomfort from HIV itself. And those may come temporarily, perhaps, from the initiation of treatment. This means that the quality of life of healthy people living with HIV actually diminishes at the initiation of treatment. I just mentioned quality of life for the first time today. WHO, in its latest HIV strategy, says that a holistic, patient-centered care approach focused on long-term well-being needs to address 3 points: multimorbidity, stigma and discrimination, and indeed health-related quality of life. For many years, the definition of success of treatment and the objective of treatment guidelines was to achieve viral suppression, which is not what is physically experienced by patients. Though I hasten to add how comforting it was to know and confirm undetectability, first as a sign of treatment success and later as the most important piece of knowledge for one's mental health, that of the U equals U, undetectable equals untransmittable. Again, for someone who may have followed the tribulations and reservations of major international and local scientific societies to embrace this scientific discovery, which, by the way, in 2011 took the award of the most important scientific discovery of the year across all disciplines in Nature. This fact shows that the public health and mental health impact was underestimated. What mattered to patients the most was not understood by many, if not to say that it was rejected with disdain for its connotation of sexual pleasure or intimacy. Back in 2016, I was part of the writing team of Lazarus et al., who in our paper with the title Beyond Viral Suppression of HIV, the New Quality of Life Frontier, we introduced the fourth 90 as an equally important target after the 390s. In essence, one that mattered to patients the most, but also guarantees the immediate previous one. The fourth 90 expresses a paradigm shift towards a patient-centered care aiming to improve and maintain health and well-being, quality of life, in essence, all interchangeable terms. It aims 90% of people to enjoy a quality of life comparable to that of the general population. Closing, I would like to stress that even the latest medicines, there are emerging signals that link them with increased diabetes or cardiovascular risk. Body or circumference gain, body weight, remain an issue. In the important recent NIH-funded trial Reprieve, adding one statin when previous guidelines did not deem necessary proved to be useful. More pills to take. Taking pills for a lifetime is difficult. And for the cohort of people living with HIV, which is aging, adding further comorbidities to those that might have been there in the first place creates a maze of different specialists and clinics, polypharmacies, and management complications. That is why fixed dose combinations, one-daily regimens, and long-acting drugs are so important. And while those improvements and delivery innovations are useful for all, there are a couple of groups that long-acting are necessary. Those include people with proven adherence trouble, people with cognitive impairment, people with housing problems, people in prisons or detention camps, people living in places with extreme stigma and discrimination where privacy is not easy. In order to achieve the 95-95 target, it is clear that the end tail of battling the HIV epidemic will require better and more sophisticated drugs to improve even the current success. Innovation in HIV therapeutics is still needed exactly because the quest for an efficacious, safe, and easy-to-take combination therapy without restrictions and discomforts is a holy grail, never attainable, but worth pursuing. Many thanks.